Hi, today I'm going to talk about cirrhosis. So I had a patient who came to the office who is a 55-year-old white male with a history of emphysema, chronic kidney disease, hiatal hernia, hepatitis C, and hypertension. He was here for evaluation of his lab results due to continuous right upper quadrant pain despite using hydrocodone. He also complained of distension, weakness, and an 8-pound weight loss in the past month. He's unable to tolerate foods at this point, and so we decided to ran lab results on him and ultrasound and CT. He was diagnosed in 2012 with hepatitis C and was treated with ribavirin and interferon and was rendered viral-free. However, on the ultrasound and the CT, it was significant for cirrhosis of the liver, ascites, gallstones, and a hypodense mass in the liver that could represent a hepatoma mass. With his labs, he had elevated LFTs, he was hyponatremic, low albumin, increased total bilirubin, and his AFP was incredibly high. He also had an increased surge of ferritin as well. Differentials, it was cancer or HCC or not. He was already diagnosed with cirrhosis, and so physical exam findings, right upper quadrant pain, epigastric tenderness to palpation. We were unable to palpate the liver or the kidneys or the spleen because of the dissension. He had a positive fluid wave test, bowel sounds active, no guarding, rebound tenderness, or masses. So we referred him to the Baylor Oncology Center and for an MRI to be scheduled because the CT could not tell whether or not there was cancer or not, and left him with the office with Lasix and aldactone for his for fluid retention. So about cirrhosis, some say it's reversible, others say it's irreversible. It depends on what stage you're at. It's progressive. Hepatic fibrosis condition, which the liver's architecture is completely distorted because of the regenerative nodules. There are lots of causes of cirrhosis. Chronic viral hepatitis B or C are your main ones. Alcohol, fatty liver, autoimmune diseases such as hemochromatosis, Wilson's disease, primary biliary cirrhosis, autoimmune hepatitis, and medications can cause it. Methotrexate and isoniazid can also cause it as well. Between 2004 and 2013, however, hepatitis C, alcohol, and fatty liver accounted for 80% of the liver's transplant list. A little bit about the anatomy of the liver. It's located on your right upper quadrant. 75% of the blood supply is from the hepatic portal vein, 25% from the hepatic artery. There are lots of functions of the liver. It produces bile, metabolizes drugs and toxins, conjugates bilirubin to be excreted, converts ammonia into urea to be excreted, synthesizes vitamin K, prothrombin, fibrinogen. It stores iron, copper, vitamin B12. It produces cholesterol, stores and releases glucose, makes albumin, synthesizes angiotensin and produces insulin growth-like factor. So the liver has a lot of important factors. So when the liver is destroyed, in cirrhosis, the pathophys, when you have diffuse fibrosis and loss of the function, the stellate cells which maintains the extracellular matrix, becomes activated and they proliferate, leading to extra deposits of collagen. This leads to fibrosis and causing severe consequences if it's not treated, if the underlying cause is not treated. At the same time, you have inflammation and necrosis of the cells. As the hepatocytes are trying to regenerate, they can't because of the lack of blood supply. So then you have these nodules that start to form on the liver, and we know them as basketball and pathophys, and the liver is unable to function. So when you have distortion of the liver, it cannot remove and conjugate bilirubin. So then you have a mixed indirect and direct increase of bilirubin, which can cause jaundice. You have the increased buildup of bile salts causing pruritus. You have decreased production of bile, which then you can't absorb fat and then you can absorb your fat-soluble vitamins A, D, K, and we know vitamin K is important for clotting. So then you have easy bruising and purpura, and then you will have an increased PT and INR. You have decreased production of albumin, which is important because you have portal hypertension going on. You have decreased osmotic pressure, so then you can't pull the fluid back into the system, and the fluid therefore stays in the peritoneal, goes out of the portal circulation, goes into the peritoneal cavity, causing ascites. When you have ascites, this can cause it can push up into the diaphragm, causing one to become short of breath. It can cause splenomegaly and esophageal varices as well. You have a decreased iron and vitamin B12 intake, causing anemia. You cannot activate your hormones, aldosterone, estrogen, causing gynecomastia, testicular atrophy, amenorrhea. And like I said, you cannot remove ammonia into urea, so then you have hepatic encephalopathy, as well as which might be signs of confusion, seizures, coma, atelectasis, and weakness. So portal hypertension, it can cause splenomegaly, causing you to have thrombocytopenia, caput medusa, hemorrhoids, ascites, esophageal varices, and generalized edema. So I already mentioned a lot of the signs and symptoms of it. Spinal angiomata, pulmonary erythema. You have chronic weakness, fatigue, dark urine, jaundice, ascites, atelectasis, and upper GI bleed as well. I already talked about most of the labs. Diagnostics, abdominal ultrasound is going to be your first initial diagnostic test. It can evaluate portal hypertension, splenomegaly, ascites, portal vein thrombosis. Liver biopsy is your gold standard, but it is not your first initial diagnostic test. Abdominal CT can be used, but it will not determine the direction of blood flow. MRI can be used as well, but that will be mainly used to differentiate between cirrhosis and HCC. So lots of complications of portal hypertension. Esophageal varices can be prevented by putting these patients on a beta blocker, propranolol, or having band ligation or TIPS. If they're having an acute attack, give them IV fluids, treat them as if they're almost going to shock, because these have a high mortality rate. Give them RBCs, FFPs, give them trocartide. Ascites, these patients need to be on diuretics and put on sodium restriction. If it becomes severe, they would need to have a paracentesis done. Spontaneous bacterial peritonitis, treated by culturing the ascites fluid, give them ceftriaxone and ceftaxamine. Hepatic encephalopathy, give them lactulose or Xifaxan. Other complications: hepatorenal syndrome, hepatopulmonary syndrome, hepatic hydrothorax, and portal vein thrombosis. Cirrhosis is the 8th leading cause of death in the United States. Use the Child-Pugh score classification to determine the severity of cirrhosis, and the MELD score to determine if they're liver transplant candidates. To manage cirrhosis, it is symptomatic and labs. Prevent insults to the liver, so give them the vaccinations that they need: hepatitis A, B, influenza, and pneumococcal. Avoid medications that could cause hepatotoxicity. If they have ascites, prevent them by diuresing them. Give them beta blockers or like variceal ligation for variceal bleeding. They need an ultrasound every 6 months to evaluate for HCC as well. These patients may or may not be on a blood thinner to prevent portal vein thrombosis. The end definitive treatment for cirrhosis is liver transplant. There's no way else around it, that they would need surgery. Tell them to stop drinking alcohol if they are. Treat the underlying cause, whether it's a viral condition or not. If they need to lose weight because of fatty liver, then that's what they have to do. So it depends on the underlying cause, but by the time they are diagnosed, most patients, it's already too late. So you just have to manage how to manage cirrhosis as well. That's it for today, and thanks.